Mani, and I welcome you all on behalf of Ashirvad Institute of Pain Management and Research to the third prologue session to our upcoming workshop. Our upcoming workshop will be highlighting the role of muscles in various pain conditions and the role of ultrasound guided dry needling. This workshop is held in association with Nair Hospital and Topiwala Medical College. Today's topic will be about sonoanatomy and applied anatomy of the shoulder. And our today's speaker is Dr. Khyati Patel. I welcome Dr. Khyati. She is
Hi.
the director at Surat Pain Care Clinic, Surat. She is MBBS and MD from DY Patel University, a gold medalist. She has done a fellowship in chronic pain management from Ashirvad Institute and Maharashtra University of Health Sciences. She has also done her fellowship in regional anesthesia and acute pain from Ganga Hospital. She has done her fellowship in pediatric anesthesia from Wadia Hospital. She is currently working in Surat for the past 2 years and working as an interventional pain specialist at Global Hospital, Sims Hospital, and Shivan Hospital at Surat. Over to Dr. Khyati.
Hi. Thank you for the intro. So today we'll discuss shoulder anatomy and sonoanatomy. I'll be covering these headings. First, starting with the myofascial pain and concepts of TRP. Then we'll review the anatomy, shoulder movements and individual muscles, and we will end with the sonoanatomy demonstration. So starting with what is trigger point. The trigger point is a hyper-irritable spot within a skeletal muscle, which is painful when it is compressed or when muscle is stretched. And this trigger point acts as a persistent peripheral nociceptive input, which is independent of extent of tissue damage. So even if the reason which started the trigger point in a muscle, even if you remove that inciting event, the trigger point can persist and it can keep causing pain unless treated. Now, what are the characteristics of trigger point? So you will feel a tight band in a muscle, a hypersensitive spot. In this video, the red arrow is showing a local twitch response when a needle is being inserted into the muscle, which is called local twitch response. These trigger points, they prevent full lengthening of the muscle, which will be seen as restricted range of motion and also as perceived muscle weakness. So there won't be any demonstrable atrophy, but patient will say he or she feels some weakness. And trigger points can also produce autonomic symptoms like temperature changes, pilomotor, and sweating, similar to and other similar autonomic symptoms. Now, what is active trigger point and what is latent trigger point? So active trigger points are spontaneously painful. Latent ones, they are painful only when they are stimulated. The active trigger point, whenever they are, the pain which is produced by active trigger point will be recognized by patient. Patient will say, yeah, this was the pain which I was complaining about. You are producing similar pain. Whereas when you stimulate a latent trigger point, patient will say, no, this is a different pain. Active trigger points, they have a large referred pain areas as compared to latent trigger point. So latent trigger point will contribute to process of nociception, but it is not spontaneously painful because the threshold which is required for activating the ascending nociceptive pathway, that is not achieved. So they won't be spontaneously painful, but they can still cause stiffness and contribute to reduced range of motion. Now coming to the importance, why referred pain and recognizing referred pain pattern is important while treating muscle pain. So first of all, it gives diagnostic precision because the referred pain which is produced by these muscles, they follow a very predictable and a reproducible distribution. Also target the therapy becomes easier because you will specifically identify the TRPs in the muscles and you will inactivate it by dry needling. So you will be producing more effective and longer lasting pain control. The treatment is not only directed at the site of pain, but also in the referred zone, and you will also be treating latent MTRP, which will give you persistent pain relief. And it also helps in patient education because you can help patient understand their condition better. And once they identify how the MTRPs were formed or what were the triggering events, they can reduce the or prevent the pain recurrence by modifying their posture or ergonomics as and when applicable. Now we'll keep talking about functional unit throughout the lecture. So what is a functional unit? It's a group of muscle, agonist as well as antagonist, and the joint which is crossed by these muscles. And why is it important is presence of MTRP in one muscle of a unit increases chances of MTRP in the rest of the muscles which are there in a functional unit. So whenever you are treating the TRPs in one muscle, you should address all the muscles which are there in the functional unit. So functionally interdependent muscles should be treated as one unit, and only then you can achieve complete pain control. So now coming to the anatomy part of it. So we'll cover these different muscles, starting from trapezius, then the supraspinatus, infraspinatus, deltoid, all four rotator cuff muscles, teres minor, teres major, rhomboid minor and major, latissimus dorsi, the tricep, and then we come to front, we'll cover pectoralis major, biceps, coracobrachialis, subscapularis, and serratus anterior. And shoulder innervation, mainly about 70% of shoulder joint is supplied by suprascapular nerve and axillary nerve. Rest of it is supplied by lateral pectoral and upper subscapular. But we won't be covering this today because our focus will be on the muscles which are around shoulder. So we'll begin with movements, the movements of the shoulder and muscles responsible for those movements. Now, why knowing that is important is because patient will give you history about restricted range of movement, that he or she cannot do this particular thing. So from there, you can narrow down on the most affected muscle and you can figure out which functional unit is affected, and that will serve as a guide when you do ultrasound guided dry needling. If it is myofascial pain, you will only do needling, and if it is something else, then you will do some intervention in addition to ultrasound guided dry needling. So first, abduction. So abduction, first 15 degrees of abduction is by supraspinatus, then 15 to 90 degrees is by deltoid, and 90 to 180 is by trapezius and serratus anterior. Here I'm only talking about the main muscles and not the accessory ones. For the shoulder adduction, muscles responsible are pectoralis major, latissimus dorsi, short head bicep, and long head of tricep. For flexion, main muscles are pectoralis major and deltoid. And accessory, it is helped with by coracobrachialis and biceps. Coming to next movement, which is extension. So deltoid and latissimus dorsi are the main extensors, and teres major, pec major, and triceps will help in this. Next, coming to external rotation, which is mainly done by infraspinatus along with teres minor and deltoid. And last is internal rotation. So subscapularis is the important internal rotator. Along with that, pectoralis major, teres major, deltoid, and latissimus dorsi also helps. So now with this background, we go and learn about individual muscles. So we start with rotator cuff muscles, first being supraspinatus. So supraspinatus muscle, the primary role is abduction, and all four rotator cuff muscle play a role in stability of GH joint. Supraspinatus is the most active muscle supplied by suprascapular nerve. This is the referral pain zone. So whenever you have TRP in supraspinatus, patient will have deep ache in the mid-deltoid region, which will radiate down to the arm up to the lateral epicondyle. There might be some pain in the suprascapular fossa region. Patient will give history that his pain increases when he is sleeping on the affected side or when he tries to reach out the opposite side, lifting arm above the head or lifting heavy objects. Now the functional unit. So supraspinatus acts along with other muscle for a particular movement. So synergist for supraspinatus is deltoid. And these are the list of antagonists, which is teres major, pectoralis major, coracobrachialis, and latissimus dorsi. So all four rotator cuff muscle, they act as synergist for any given movement. So when you have the pain pattern like this and you are suspecting that supraspinatus is the main muscle which is having a lot of TRPs, you will address not only supraspinatus, but all these muscles. Okay, so coming to sonoanatomy, here I'll discuss only in a short way. In the end, we'll have a proper video showing all the sonoanatomy. So this is the probe position, the blue line which you can see on the left. If you keep the probe like this, you will be able to see trapezius, supraspinatus, and then the notch showing suprascapular nerve. So the suprascapular nerve is targeted in for acute pain. You can do phrenic sparing nerve block for shoulder surgery and post-op pain relief. And in chronic pain, PRF can be done there or steroid injection for any of the shoulder pain conditions. Coming to the next muscle, which is infraspinatus. So again, being a rotator cuff muscle, it provides stability to the joint and also responsible for external rotation supplied by suprascapular nerve. Now, this is the pain pattern referral diagram for infraspinatus. So patient will have deep ache in the anterior part of shoulder, which will radiate down to the arm, up to the forearm, and even in the hand, radial aspect of the hand. Sometimes also in the medial part of the scapula. Next is teres minor. Again, being a rotator cuff muscle, it provides stability and also helps in external rotation. It is supplied by axillary nerve, and trigger points in teres minor will cause deep pain in the posterior part of shoulder. Infraspinatus and teres minor, they act like one unit. So synergist for that are teres minor and posterior deltoid, and antagonist will be subscapularis, pec major, latissimus dorsi, and anterior deltoid. And for scanning, patient can be in the lateral or prone position. And when you put your probe like that posteriorly, here you will be able to see infraspinatus and the posterior part of shoulder. If you scan the probe, if you take the probe downwards caudally, then you will be able to see infraspinatus as well as teres minor. Coming to the next muscle, subscapularis, which is largest of all the rotator cuff, provides stability to GH joint as well as internal rotator, also helps in adduction. It is supplied by upper and lower subscapular, and trigger points in subscapularis play a key role in development of frozen shoulder. So this is the pain diagram for TRPs in subscapularis. So mostly patient will have pain in the posterior part of shoulder and also in the just above the area above the scapula. It will radiate to the back of arm and wrist. Pain initially in the abduction and external rotation will be difficult, but later on patient will have pain at rest, won't be able to reach on the opposite side, may even complain of clicking sounds around the shoulder with movement when he tries to do external rotation. So this muscle is located deep inside. So little difficult to reach with ultrasound, but we'll discuss it later, how to see it on ultrasound. Now coming to the action, internal rotation and adduction. So the synergist and antagonist are given in this table. Also being a key internal rotator and stabilizer, whenever there is subscapular dysfunction, the shoulder stability will be compromised. And most commonly, the subscapular tears are associated with biceps pathology, whether it is subluxation, tear, or fraying. Next is deltoid, which is responsible for abduction, flexion, as well as extension, supplied by axillary nerve. And patient will complain of pain in front of shoulder, upper or the lateral arm. Also will complain of difficulty in raising arm to the shoulder level, may have painful weakness. The pain diagram for deltoid will depend on which fibers are affected more. So anterior deltoid fiber will have TRPs in anterior deltoid will have pain in the anterior shoulder and the anterolateral upper arm. The middle deltoid will have pain localized deep within the shoulder, and the posterior deltoid fibers will produce pain in the posterior part of shoulder as well as posterior part of the upper arm. So these are the other muscles of the deltoid functional unit. And deltoid is primarily mover, whereas rotator cuff muscles are mainly stabilizers. So being a primary mover, when other muscles are weak, of rotator cuff muscles are weak, then the deltoid will take over, and because of overuse, you may develop secondary pain in the deltoid. Coming to trapezius. Trapezius was already covered in the last session on neck pain. So depending upon which zone of trapezius is involved, patient will have symptoms. In the upper trapezius, pain will be, a patient will have headache and back of neck pain. In the TRPs of the middle part of trapezius will produce interscapular area, spinous process, and mid back pain, whereas lower trapezius will produce pain in the medial border of scapula and the upper back. Coming to next muscle, which is latissimus dorsi. It extends, adducts, and internally rotates the humerus. Also important for lumbar extension, trunk and pelvic stability, and respiration. So being a big muscle, it is involved in multiple things. Coming to history part, patient may not be able to say exactly what aggravates his pain, but there may be, long history of negative diagnostic procedures, bronchoscopies, negative chest, CT chest. These are the pain regions. So TRPs and latissimus dorsi will have pain in the inferior angle of scapula. That is the main pain zone. The other, the spilled over pain will be in the mid-thoracic region or anterior shoulder, right above the iliac crust. And being a big muscle, it covers large surface area and acts as synergist and antagonist to different muscles for various movement as given in this table. And another important landmark when scanning will be teres major and latissimus dorsi. They both join together and they form conjoint tendon when it inserts onto the humerus. So this is one important landmark when we are giving axillary nerve block. So your probe will be in the posterior part of shoulder, and then you will be looking for neurovascular bundle. which is near the conjoint tendon. So axillary nerve, posterior circumflex humeral artery, and radial nerve will all be in that vicinity. Coming to the front of shoulder, there is pectoralis major, which is responsible for the adduction, flexion, and internal rotation, supplied by medial and lateral pectoral nerves. And these are the pain areas. So TRPs and pectoralis major will have pain around the clavicle, parasternal area, anterior chest wall, anterior shoulder. Pain may radiate down to the arm, medial epicondyle, and ulnar part of the hand. And this muscle has role in post-mastectomy pain syndromes, whether it is modified radical or simple mastectomy. Pectoralis major will have TRPs, and there might be viscerosomatic activation, and pec major may develop TRPs after MI. And these are the synergist and the antagonist for the pec major. Next is biceps brachii, mainly responsible for elbow flexion and supination, supplied by musculocutaneous nerve. Trigger points in the biceps will be seen as pain in the midarm and the anterior deltoid region. Next is teres major, which is responsible for internal rotation, extension, and adduction. And the trigger points will produce pain in the posterior shoulder, and there won't be much movement restriction. Next group is serratus anterior. So trigger points in this will produce pain in the anterolateral chest wall, inferior angle of scapula, and radiating to the medial arm. And these TRPs in the serratus anterior can result after mastectomy or post-thoracotomy surgeries. Next muscle is coracobrachialis, which is responsible for shoulder flexion and adduction. Patient will complain of pain when he or she tries to reach the back pocket. There will be usually history of repetitive movements like push-up or bench press. Then we come to triceps, which is mainly responsible for elbow extension. This is the pain diagram. So mainly there will be pain in the middle of the back of arm. You can also have pain in the back of forearm, radiating up to posterior shoulder. And then rhomboid minor and major, they help in scapular elevation, retraction, and downward rotation. And this is the pain diagram for the rhomboid TRPs. It's a busy slide. It's about origin and insertion of all these muscles that we discussed. So this will be discussed during the cadaveric dissection of the workshop. So I won't discuss each and every one. Okay, so now with this background in anatomy, we'll go and scan. So starting from anterior shoulder with patient in supine position, we will be seeing pectoralis major, minor, serratus anterior. That is the ultrasound image where you can see pec major, minor, the ribs, which are black shadows are the ribs. In between you could see pleura, which is white. As you scan downwards, serratus anterior will appear. Now we take probe towards lateral to earlier position, and we will be able to see deltoid. The round one is the biceps long head, which is located between the greater and lesser tubercle. As we go more down and medially, we will be able to see coracoid process as well as origin of short head of biceps, and coracobrachial is there. Beneath that is the subscapularis. So this will be the probe position, and this will be the ultrasound image. So that's the coracoid process coming up. Sorry. Yeah, so that's the coracoid process. And then as we scan it downwards, you can see coracobrachial is there. As we keep scanning downwards, the deltoid will get over and you will be able to see biceps and the brachialis underneath. So that's humerus and the biceps above that. Next, patient in prone position, we start scanning from the suprascapular area, where we will see trapezius first. Beneath that will be supraspinatus. So that is the ultrasound image, and that's the probe position. Here you can see skin subacute, and then the trapezius and supraspinatus. That is the spine of scapula. As we go further down, we can image infraspinatus and teres minor. So that will be the image. This is one interesting picture I found, where that is the humerus. The first finger is the triceps, and this is helpful when you are giving axillary block, either for PRF or for anesthesia. The posterior quadrangular space from where the posterior circumflex artery and axillary nerves come out. Now coming to the midline, we can see rhomboids, trapezius, and beneath that will be the rhomboid. So here you can see trapezius, rhomboid, and then alternating ribs and pleural space. Now last is subscapularis. So it's a deep muscle. So we need to put patient in lateral position with arm abducted so that the scapula comes out, and then the subscapularis will be approachable. So this will be the probe position, and this video quality is not that great, but it conveys the message. So here you can see on the left side, you can see scapula. The beneath the bright white part is the thoracic wall, and next to the scapula you can see subscapularis muscle. These are my references. Thank you.
Thank you so much, Dr. Khyati. It was a wonderful, very, very informative presentation. You've broken down the very complex and confusing shoulder joint and a shoulder patient muscle by highlighting the function and highlighting on how the dysfunction will present to us. So thank you so much. Now, before we move on to the question and answer, I would like to welcome and introduce Dr. Lakshmi Vas, the founder and director at Ashirwad Institute of Pain Management and Research, and consultant and honorary pain physician at KEM Hospital and Burns Institute, Airoli. Welcome, ma'am. There are a few questions in the chat box. One question, they want to know whether we can identify a trigger point without putting a needle on USG. Ma'am, if you could highlight.
Welcome everybody. Am I audible?
Yes,
Yes.
ma'am.
Welcome everyone. And Khyati, that was a very succinct presentation. I liked it because it was very much to the point about what you need to know in shoulder rather than telling us origins and insertions, which puts everybody to sleep anyway. So anyway, now I want Khyati to answer that question about how do you identify a trigger point?
So on palpation, you might be able to feel it. On ultrasound, only when you stimulate it, you will see the local twitch response. You might be able to see jump sign. And without inserting needle, if the trigger point load is too much, you might see muscles, shivering, shaking kind of a thing. But once they are stimulated with needle, then you will definitely be able to see LTR. Ma'am.
Yeah, it is more of a, you see, when a patient comes and tells you, I have pain in my, posterior part of deltoid like that. Khyati showed the referral zones for many muscles in the back of the deltoid. So you will have to expect to find these trigger points in all these muscles, be it the posterior part of deltoid, be it the latissimus dorsi, be it the infraspinatus or the teres minor especially. So all these muscles will refer to the back of the deltoid. In fact, others also, even subscapularis and others. So you go to these muscles and see if there is any, even in a muscle which is at rest, there may be some twitches going on. That's a way to know that there is a trigger point there. Sometimes, I mean, most of the time, unless the patient is in severe pain, you won't see activity in a resting muscle. Then just strumming the muscle like this, like what do you call it, guitar strumming the strings of a guitar. If you do that, you may feel that there is a jump there. That is the jump sign that she was talking about. Or even pressing on it will get you that. But most of the time, when a patient says, look, I have pain in these areas, you have to sort of analyze which muscle will be involved and go for needling of that muscle. And when you do the needling, obviously you will see the twitches. Then that proves that there is a trigger point there. Does that answer your question, whoever asked that question?
Dr. Manasa, and I cannot read the other name. It says iPhone 14. So these were the two people who wanted the answer to this question.
Does that, whatever I said, did it answer your question? See, also what happens is when we start treating these patients with, let's say, ultrasound guided dry needling or PRF or whatever else, you find that each pain starts resolving by itself. The back of the front of the deltoid stops hurting. The biceps area stops hurting. And the brachioradialis is one of the very common areas for pain in shoulder pains. So though brachioradialis is actually an elbow muscle, you will always find problems in brachioradialis with shoulder pains. So as you start needling these areas, all these pains disappear. And the initial few sessions, you will see LTRs, local twitch reflexes. But as the patient starts sleeping well and is getting better, the LTRs start disappearing. They are no longer there. So this is like a retrospective proof that there was a trigger point there. And of course, when you do the needle, you will see the twitches. Twitches, sometimes it becomes, twitch. It may not be just one twitch. One needle may elicit 2-3 twitches. initially, but later in the next session, it will be just one twitch. And maybe in the third or fourth session, it will be one half-hearted twitch. It won't be even seen much unless you're paying attention to it. You will not even see it. Yeah, I think we should go to the next question since whoever asked the question is not responding.
Yeah, moving on to the next question. What shoulder conditions are responsive to dry needling therapy apart from trigger points?
The question would be, what is not responsive? Everything is responsive. Let's say, what I always see is when people go and do radio frequency procedures or nerve block procedures, they focus only on the suprascapular nerve because they believe that that is what supplies the joint. But actually, just doing the suprascapular nerve will not solve any of the pains because the pain is not coming from the joint. It's coming from all the muscles which move this joint. So when you give a suprascapular nerve block, you are doing about 10% of the pain relief for that particular patient. Then you should go and do needling of all the other muscles. And what we follow in Ashirvad, and which I'll be speaking on the third day of the conference, is the other innovative treatments that we do at Ashirvad for shoulder pain, knee pain, etc. So we do radio frequency, that is pulsed radio frequency procedures for tackling all the nerves of the shoulder. Like just now, Khyati showed you the pain referral zones for so many muscles, which means in any shoulder pain, all these pains will be there. And we have to tackle all the nerves that supply these muscles. That is the starting point. And then we start with the dry needling. Shoulder pains can be very, very severe. If, when the patient comes, if you start with needling, probably the patient will disappear after the first session. Unless you give nerve blocks first, or even better, pulsed radio frequency of all the nerves that supply the shoulder joint, which will mean all the, starting for the trapezius. Trapezius is a major contributor to shoulder pain. So you will have to do the spinal accessory, dorsal scapular, you will have to do the pec 1 and 2, and very important, the circumflex nerve, which supplies the deltoid. Khyati pointed out that is deltoid is the mover and the rotator cuff muscles are the stabilizers. So you will have to look at not just the suprascapular nerve, but also the circumflex nerve, what supplies the deltoid, the musculocutaneous nerve, radial nerve, which will go down to supply all the extensors which hurt in shoulder. So it has to be a very comprehensive procedure if you want to address the shoulder pain. And then usually after this kind of a procedure, the next day the patient comes and tells you, I slept well and I am better. And then we start with the needling. It's kinder to do it after that when the needling is no longer so very painful to them. And when you come for needling, every muscle you have to target, whatever she mentioned. And as we do this, not only do the pains come down, the patient's movements start improving. The worst movement or the last movement to come will be the extreme internal rotation, which is executed by the subscapularis muscle. I do not know how many people really acknowledge subscapularis as an important muscle in shoulder pains. But take it from me, it is one of the most important muscles. Unless you have relieved the pain in that muscle, your shoulder pains won't go. The back, especially the back of the deltoid pain, will not go. So whenever a patient comes, we also do some steroid injections for the deltoid, biceps tendon as well. So anyway, I'll be talking about it later, so I will not go into that. particular thing. So our protocol is like this. A patient who comes with anything more than 7 pain, 6, 7 pain, it is pulsed radio frequency followed by needling. And of course, medication goes for everybody, whether, whether we are giving Lyrica or nortriptyline or whatever else, along with a painkiller. But first PRF and then only needling. If the patient cannot afford PRF, then we just do nerve blocks with local anesthetic and a little steroid and start doing dry needling. And if the patient is, even if the patient is not affording, we will do the block at whatever cost and then start the needling. And for patients who have about 4 to 6 pain, they can tolerate dry needling without any cover of a nerve block or PRF. So for those patients, we simply do needling. And for those with even lesser pain, obviously it's only needling. And then physiotherapy is a must for all these patients, and all the stretches and other things. We have a full program which sort of determines what all we should do in shoulder pains. Yeah, very long answer for a short question.
Yeah,
Lakshmi,
ma'am.
Mary here.
Oh yeah, hi Mary.
I just wanted to know, how often do you have to give pregabalin and nortriptyline for shoulder pains, like frozen shoulder and things like that? You think
Always.
it be
Always.
beneficial?
Yes, always. I am more fond of pregabalin because I feel that it's more specific for as a muscle relaxant. This is an action which is not really known about Lyrica, that it's quite a bit of muscle relaxation it produces. So which helps me a lot with the ultrasound guided dry needling. Another thing I forgot to mention is Khyati did mention about post-mastectomy pain syndromes. These are patients who are really, really suffering with very, very severe pains. For these people, if you do this, PRF followed by needling, you will be astonished to see that they recover completely almost. So that's another thing I wanted to say.
Lakshmi, first, can I just take a minute?
Sure.
Khyati, you did a very good presentation. Okay. Acha, the other thing is, I just I don't have facilities to give PRF, but I had a very, very, I mean, I'm just anecdotal. I don't know how far it's okay. But this lady had come from Dubai. I don't know whether I mentioned my friend's sister. She was in so much pain because of her shoulder that she literally had gone into depression, insomnia. She was crying. And she's a 45-year or 50-year-old lady. And I just did needling for her. And I think I did about 7 sessions of needling. I discussed it with you. You said it'll be kinder to do PRF, but because I don't have that facility, I gave her what I could, and that was only dry needling. But she went back to Dubai with all most of her symptoms resolved. She did try to go there and try to find someone. Nobody was doing dry needling over there. So she only stuck to physiotherapy. But I met her now, which is about a year later. She came for TM joint and plus a function. But she says her shoulder pain had become completely all right. So this is just anecdotal, but I thought I'll share my experiences.
See, that is correct also, Mary. The final common factor in shoulder pains is muscle. So ultrasound guided dry needling is actually a whole treatment. There is no need to do other procedures unless you want to relieve the patient quickly. Your patient, as you said, you didn't have facility or access to PRF, so you just did dry needling.
Yeah.
So then what you have to do is you have to, you may have to do very gentle needling, few needles for the first session, call them in a second session, again do gentle needling only. Third session onwards, you start proper needling. Then you can manage like that. But it is like shoulder pains are quite bad. Half of them won't be sleeping. They'll all come like crazy people, hair uncombed and barely dressed kind of patients. So for them, PRF makes a lot of sense.
Yeah,
Or
agreed.
if not, you can simply do a steroid injection in this area. That is for the tendon of the biceps. You always see effusion around the biceps tendon.
Mhm.
And also at the insertion of deltoid, you can do. And at the coracobrachialis, if you go here and do some steroid injection, that makes life easier. Then you can do needling thoroughly.
Thank you. Thank you, Lakshmi.
Somebody has asked a question, how many sessions of needling do you need? Normally about 10 to 12 sessions for a full movement to come back. Pain goes down by after about 2 or 3 sessions of needling if only needling is being done. If PRF is being done, after PRF, the next day the patient is very happy. And after that, when we start doing the needling, it's a very steady improvement of movements. See, with our Ashirvad approach of ultrasound guided dry needling, pain relief is a given. It's going to happen. That is for sure. But the मारामारी हमारा इसमें चालू होता है, movements full आना चाहिए. When I say movements full, you need movements like this, and more than that, going like that. So all these are movements which have to come back. So about 12 sessions of needling. And if the pain is very severe, PRF and needling. If the pain is less than 5, 4, or even 6, just needling is enough. Somebody has asked a question. Dry needling is better than local anesthetic injection into TRP. There is a study long time ago where they have done local anesthetic injections and dry needling. These people have also given steroid injections. They've also given Botox injections. Out of all this, Botox works the longest. There is not much difference between local anesthetic and dry needling. Steroid gives you good relief, but it's short-lived. Unless you follow it up with needling, all the pains come back. When you just do needling with successive sessions, pain definitely goes and stays down. In case of partial tear, what do you do with a tear? The question you have to ask is, why is there a tear? The tear happens because the muscle is shortened. Tear is common in the supraspinatus, most common. And other muscles also show tears, but I think supraspinatus tear is the most common amongst the shoulder muscles. Subscapularis also you may see, pec major also you may see. So in all these conditions, needling is the treatment to be done, because what treatment can lengthen a shortened muscle? It is only needling which will do this. And also what happens is, let's say there is a tear like this with a gap in between. So when you do needling on this side and this side of this particular tear, the fibers will relax and meet. So the healing becomes easier when you do dry needling. So partial tears, complete tears, definitely needling is the treatment.
Just had one more question. Is when people come like this, as a diagnostic test, what would you recommend? Would you ask for ultrasound from outside laboratory or an MRI?
You mean for a tear?
No, for shoulder pains, which are very severe. What is a diagnostic test that you would like to have before you come to the diagnosis?
See, my only concern is
many
if there is a
people are
patient.
coming with MRI. Is an MRI an absolute must, or just an ultrasound is enough?
No, if they have a radiating pain down the arm with a patient pain starting in the neck and going down to the hand, then I think it may be safer and to do an MRI. Just
that is MRI spine. I'm telling MRI shoulder.
Yes.
Shoulder.
No, I'm not looking at shoulder. I don't think of shoulder MRI at all. I am looking at, see, it becomes a differential diagnosis. Is it a shoulder problem or a neck problem giving a secondary shoulder pain?
Yeah,
if I'm thinking whether that there is a C5-6 disc causing shoulder pain, then it is just treating the shoulder becomes half treatment. You have to treat that C5-6 or C6 or whatever, C6-7 protrusion or prolapse or whatever there may be. So, or even a tear, annular tear in these areas can produce quite severe shoulder pains. So when there is a pain which is starting from the neck and going down to the hand, and if it looks like a discogenic pain, you should ask for MRI. Otherwise, I don't ask for any investigation at all. If I'm thinking that this is a shoulder issue, the only investigations I ask are, vitamin B12 and D3. And I don't even ask for X-ray. Sometimes, some of my educated patients, they'll say, do you think I should do X-ray? Do you think I should do MRI, etc.? I tell them, okay, go and do an X-ray if you wish. It's not going to give me much information, but if it makes you happy, go and do it. I usually don't ask for shoulder MRI. If there is a suspicion of a tear, then definitely I will ask for an ultrasound from an ultrasonologist, because I want to know, is it a complete tear? Is it a partial tear, or are there many partial tears or other muscles involved in the tear? So our machines, our Sonocyte machine, etc., it's not really a diagnostic quality machine, and nor is our quality of ultrasound knowledge that good in diagnostics. So I will ask for a ultrasound.
Yeah.
A tear.
But the thing I just sorry.
More than that, see whether there is a suspicion of a tear or not. I will do a needling and send this patient.
Yeah.
Because patient becomes comfortable at least. Even if there is a tear, I'm going to do needling only.
Okay, the other thing I just wanted to share with everyone from my experience is the same lady who had the frozen shoulder. I told you, her older sister is my friend, my schoolmate. She had come with very severe shoulder pain, and she said it was worse than labor pain. It was so bad. She came, and then I was because she's a friend, close friend, very highly connected. I said, you must take a neurosurgery opinion also, I said. So I referred her to one of the top neurosurgeons. She was diagnosed as having very severe degenerative changes at C5-6 and C6-7. This, as well as, a lot of osteophytes and all impinging on the nerve. Surprisingly, he said, I will not operate you, because most neurosurgeons would have said corpectomy and blah, blah, and all, they would have gone on. But this is a gentleman I sent to who is most likely he would say that operation is not required, that kind of a neurosurgeon. So he told her, you do what you want, do physiotherapy, do everything, but there is no need for surgery. Just take pregabalin. And then I had the confidence of going and doing her needling. And she really improved after the needling. But to be on the precaution, I just got a neurosurgery opinion. So the origin of pain was because of the degenerated cervical spine, particularly in that C5-6, C7 and all. And she's a lady who's 65 years old, not a young person with a isolated disc prolapse, but she had also got degenerative changes. But her pain, she said, was worse than labor pain, that kind of pain she had.
She must have forgotten about her labor pain. But I'm not belittling shoulder pains. But see, the thing is, if there is a 5-6 problem, the shoulder pain is likely to recur because you have not addressed the primary cause. So if she is good, I'm happy. But sometime or the
now it's 3-4 years after that. But she's not got a recurrence.
Maybe you had done some needling of the neck as well, and maybe that was the saving grace.
Yes.
There. Yeah, there are some questions here. Can you share supraspinatus picture that Khyati will do just now? I'll answer the other question, then Khyati can show. What is the suggested time for each dry needling session? Usually, I do 2 sessions a week for the patients with the pain. Once the pain comes down, then I make it once a week. And usually within 3 sessions, pains will come down if it is only dry needling. If it is PRF and dry needling, I can go for once a week only, because with PRF anyway, they come down in pain.
We
Yeah.
had a few questions.
No, you show that supraspinatus needling.
The needling picture. Needling, I don't have.
Then we'll show it in the conference. You
Yeah.
will see more than enough of needling. You will see direct needling being done during the workshop.
Madam, what about calcification in rotator cuff?
That some people, they inject a lot of saline and do little bit of this thing and all.
Barbotage they do.
Barbotage, as well as I think they call it something else, the pecking that they do. It is done. And I believe that it is supposed to dissolve the calcium. And I feel, it's a short-term remedy. You are trephining, they call it trephining, is it? I thought trephining was something neurosurgeons did. Anyway, whatever it is that they do to peck at the calcified area, I feel, if you go and supply blood to that area, it will calcify some more, I feel. It'll, in the early phase, it will relieve, but maybe later it may become worse. I'm not very sure. So I usually simply go there, maybe do a little gentle needling of that area, and that's about it. I don't do barbotage or anything like that. Yeah, any other questions? I can't see any questions.
We missed two. What all sessions? Will all the sessions of needling be preceded by PRF? And
No, I told you that PRF is done only for patients with pain more than 6 on 10. Or if, the patient says, look, I am here for a short time, treat me, get me better and send me. So then I may do it even in lower pains. I'll do PRF and then do the needling, so that within 3-4 sessions, they settle.
And how many sessions and at what intervals?
Usually, as I said, twice a week till the pain goes down, once a week after that. But then if somebody has come from outside Mumbai, many times people do, they have come from some other city, some other country. Then, of course, it's you pull out all the plugs. You give them PRF, you do needling, or if you find that there are too many jumpy muscles, I may give Botox as well. So it all depends on the requirements of the patients. But in general, it is once a week needling.
There's one more question that we missed, but it's almost answered. Is there always a possible muscular component, be it adhesive capsulitis in shoulder or OA of knee or any other joint? And does needling serve for pain relief in all of these conditions?
See, 20 years of experience with shoulder pains, I can tell you, I have never seen anyone where who did not improve with needling. So muscles are always involved. You have to understand that there is something called as Hilton's law. If there is an irritation of the joint, all the muscles that move the joint will go into spasm. So always there will be myofascial trigger points in all these muscles. Also, you have to understand shoulder is a joint which is very unstable. The stability is provided by the muscles, and it is the same muscles which move the joint as well. So it's contradictory requirement from the muscles in shoulder. And it is because of this that there is something like a domino effect almost. The patient says, I have pain today, and then within 2-3 days, it is much worse. And then within a week or 10 days, they're in quite severe pain. It is because of this, what Khyati said, the functional unit, all the muscles of the functional unit get involved very quickly because one muscle is involved. And usually, many times, the culprit in these cases is a low vitamin D3 level. Somehow, I think it's D3 is something like a self-healing vitamin. If D3 is deficient, their healing becomes very much defective. And as a result, they go into cascades of pain suddenly, very quickly. Yeah.
How deficient is deficient?
That's a very good question. Because according to the laboratory, anything less than 30 is insufficient and deficient when it is below 20. But the range is 30 to 100, which is like Zameen Asman Ka Farak Hai kind of thing. So I usually take the midpoint. I take 75 as normal. So for me, unless the D3 level is 75, it is less. So even in a patient who's got 30, I will give an injection of D3. If the patient is coming with a 12, 13 or 20 or something like that, these people will get 2 injections at intervals of about 15 days or one month. And I always recheck, because D3 is one which can go for hypervitaminosis. So if I have given at 30, I have given one injection, I will check before if I want to give another one. But most of the time, by the time the second injection becomes due, the patient has disappeared because she is pain-free, she or he.
Thank you, Lakshmi.
Another question, can ESP block work?
What is ESP?
Erector spinae plane.
Okay. Yeah, erector spinae block will help to some extent, because you see the rhomboids are involved, the trapezius is involved. All these will get relieved by the erector spinae block, but it will not really hit all the shoulder muscles. The nerves which supply the shoulder, especially the levator scapulae, which is very much involved in these shoulder problems, it is supplied by the dorsal scapula. Dorsal scapular and axillary are coming from the superior trunk of brachial plexus. Unless these get blocked, your shoulder pains are not going to go. See, deltoid and suprascapular nerve are very, very important. But that is not to say that PEC 1 and 2 are less important, or musculocutaneous is less important, or the nerves that supply the first and second nerves which supply the subscapularis are less important. All of them you have to address. So in an erector spinae block, all these are not touched at all, unless you are doing erector spinae block at C3 and 4 level, which I doubt that you would do. I mean, that area is quite a risky area to go into, and you also have the vertebral artery in that area. If you want to go and touch the transverse process and then do the erector spinae block. So doing an erector spinae block at T1, 2 or T2, 3 is not going to really hit all the components of pain in shoulder.
Thank you, ma'am. One more doubt, ma'am. How much Botox can we give to avoid any, residual winging of scapula or any other complications?
I can't answer you at all, because the doses are very dependent on ultrasound guided dry needling findings.
Okay.
Because if I see a very irritable muscle, I will give 10 units or 15 units there. If I find that it is not very irritable, but the patient still has pain, and for that I may go for less. So it is like, it's case to case almost, it comes to.
Okay, ma'am. Okay,
But
ma'am, I understand.
yeah. So, and you see, one muscle you hit with Botox, something else will go wrong somewhere. So you have to balance the antagonists as well. So you will have to keep a record of what Khyati showed about the agonists and antagonist combinations. And you have to hit
Okay.
all the muscles, all the muscles.
Yeah. Okay. Okay, ma'am. Thank you
Yeah.
so much. Thank you.
Yeah. See, you usually don't go much for Botox in shoulder cases. My go-to treatments are PRF and needling. Botox is only an addition only if somebody is come from abroad and he's here only for about 7 days and has to go away and things like that.
Yes, ma'am. Thank you.
One more question. Sometimes patient complains of increased pain and stiffness after 1-2 sessions of needling. What other measures to be taken? Any analgesics?
See, you have to cover them with analgesics, because you have to understand that when you are doing dry needling, you are putting needles into a muscle which is already stressed out. You are relieving the myofascial triggers, no doubt, but it is a micro trauma which is happening because of the needles. So it's always a good idea to give an analgesic before the needling. Something like aceclofenac or naproxen or even simple paracetamol. And I also give Lyrica, low dose Lyrica, 1/3, half, etc., to make the needling easier. And that itself continues for the next almost a day. So then there is no pain on the day after the needling. Yeah. Yeah, what is the some question here? A PRF of suprascapular nerve only or other nerve needs to be done? See, it is like doing suprascapular nerve is like addressing 20% of the problem or 10% of the problem. So all the other nerves need to be addressed if you want the patient to become fully all right. You have to look at the pain referral point pattern, look at which muscles are involved, diagnose which muscles are involved, and go to the nerve supply of that and do PRF.
What complications are common?
If you're doing ultrasound guided procedures, pneumothorax should not be the complication. Pneumothorax can be a complication only if you are not familiar with anatomy, and it's a part of your learning curve. But if you know how to do ultrasound, you know how to look for pleura all the time. And when you're looking at pleura, it's very difficult to go and touch it, isn't it? So pneumothorax is touch wood. I haven't seen pneumothorax after our procedures anytime. Yeah, I've touched wood. Yeah. See, especially when you do ultrasound guided dry needling in the chest, especially for things like, post-mastectomy pain syndrome and other things, where you are going and needling muscles like serratus anterior and pectoralis minor and the subscapularis. You learn how to look for pleura and to avoid it. You almost get something like a sixth sense for the pleura. Your eyes are always looking for anything white moving in the field, and you will stay as far away from that moving white shadow as possible. Yeah. All questions over or
Yes,
there?
Yeah, we've addressed all the questions.
No, actually the question was what complications are common other than
pneumothorax.
One of the most common complication is bruising. That's the only complication we see very commonly. Other than that, not really. You can think of anything else? Post-needling pain, not really when we are covering them with painkillers and Lyrica. That's about it, I think. And some patients who are very low in D3 and all that, even though you have corrected, it takes 1 month for it to assimilate into the body. These patients may come with a little more pain. So for them, you might have to go up in your background analgesic therapy by giving them something like maybe tramadol or something like that. I mean, that also we give very rarely. I don't think we give it much. In fact, after PRF, we don't need analgesics much at all. They only take the analgesic on the day they come for needling. But they continue with pregabalin or other drugs, whatever we may be giving. Sometimes gabapentin, sometimes nortriptyline. Those continue.
What
I
type
think
of
there is one.
Yeah, what type of needle is used in dry needling? Does the gauge change according to muscle joint or is it same?
It is same all through, except I think you see our smaller needles. There is a 13 mm needle, which is I think 34 gauge, and most needles are 32 gauge. Sometimes, the longer needles, like the 100 mm or the 120 mm needles, sometimes are slightly thicker. Maybe they are 31 or 30. Yeah. Madam, role of needling in neuropathic conditions, 100% role, because no pain is neuropathic alone. It's all neuromyopathic. See, unfortunately, science has been hijacked by a few European and American neurologists who have confined neuropathy to somatosensory nervous system. It is very wrong definition. All these neuropathic pains are neuromyopathic pains, and the muscles are always involved. And if you do needling, results are always fantastic. So what is that soft tissue metastatic mass? Some question is there. I can't see the, 1 minute. Metastatic mass at scapula doesn't respond to radiation therapy. Pain at the region radiating to shoulder. What can we do? See, it's metastatic mass means it's difficult to do needling around it because you can cause quite a lot of bleeding. Metastatic mass will be vascular. So at the scapula, where in the scapula? Is it something which is stretching the latissimus dorsi, or is it something which is stretching the trapezius? Which part of scapula? I don't know. But if in these cases, if you can stay out of the tumor but go into the muscles around it, Botox will work very well in these cases because that will immediately take care of the stretch pain and other things. Other than that, you will have to look at probably, since it is around the scapula, you might have to go and look at the dorsal scapular nerve. Lactating mother, then if she is a lactating mother, just tell her to grit her teeth and tolerate the needling, because needling has no medications involved. And I have treated some lactating mothers like this. We do gentle needling for them. We call them more often so that, they achieve pain relief. Or I think in some lady, I remember, I would tell her, you just feed your child and express milk and keep it, feed your child and come, and don't feed the child for the next 8 hours, so that you would have excreted the whatever we have given.
Vitamin D injectable or oral?
Always injectable. Oral is only if the patient is already having something like 50, 60, then I'll say, you are on maintenance, take oral. Correction is always injection. Yeah. Yes, iPhone 14. Could you identify yourself, please? Please unmute yourself and say what's your name. It's not really nice to call you iPhone 14. Okay, maybe he has left after asking the question, he or she. Yeah, leave it then, that question.
Okay, ma'am, I think we are at the end of the question answers.
Okay. For the benefit of others, yes, all somatic muscles can be needled. That's for sure. Okay, we call it a day.
Yes, ma'am, we can conclude. And thank you, Dr. Khyati, Thank you, ma'am.
Thank
And
you.
thank you all delegates for being present and for such an interactive session. We'll
Thank
see
you.
you all at the workshop. Thank you.
Thank you.
Thank you.
Bye.
Bye. Where do I leave?